Hi, everyone. We're going to give everyone a second to kind of pop into the Zoom here. I see the number rapidly rising, which is great. And then we'll get started in a couple, I don't know, probably 30 seconds. Please feel free to drop where you're tuning in from in the chat. It's been great to see that we've had people tune in from to these briefings from all over the country. So we'd love to kind of see the diversity of places. That's been really fun. So, and introduce yourselves, share whatever info you like. Few more seconds here. DC, we love that. Oh, Cali, nice. I have no idea if that's the cool thing to call California. Excuse me if I butchered that. Awesome. Well, as everyone kind of pops in and starts chatting, which is fantastic, I'm going to get started introducing the show here. So, good afternoon, everyone. Welcome to today's briefing, our last of 4 in this series that we've been doing, diving into some of the major elements of the Big Beautiful Bill. As we get settled in, like I said, I hope you'll drop a note in the chat, just telling us where you're tuning in from, even, what you cover, where you work. I'm Allison Prang. I'm the Professional Development Coordinator for the National Press Club Journalism Institute in Washington, D.C. I know some of you might have attended the 3 other briefings that we've had as part of this series with the Bipartisan Policy Center. But for those of you who might be new and joining an event with the Institute for the first time, just a little bit of background for you. The National Press Club Journalism Institute is the nonprofit arm of the National Press Club in DC, and we focus on supporting and training journalists. On behalf of both the Institute and our colleagues at the BPC, thank you so much for joining us for this important informational briefing about the Big Beautiful Bill that became law early last month. The Institute's mission is to power journalism in the public interest, building the skills and standards for journalists to do that work effectively and to earn the public's trust. Today's topic couldn't be more relevant to our national discourse at the moment, and we hope this briefing and the others we've already held in this series, most of which, by the way, you can see the recordings for online. We hope this will help journalists and really anyone in the journalism space help make sense of the law for their audiences. It goes without saying that there's going to be some wonkiness and lots of policy jargon in any 1,000-page bill, which is why we're hoping, and we've been blessed to have the staff from the BPC kind of walk us through different facets of it throughout this 4-part series. On that note, I want to share a bit more about the BPC, who we are delighted to produce these briefings alongside. The Bipartisan Policy Center and its advocacy affiliate, BPC Action, are unique in their approach to addressing the nation's most pressing issues. As the only organization working across the full political spectrum on domestic issues, the BPC brings together diverse perspectives to craft data-driven, pragmatic policy solutions. BPC Action then works directly with legislators and other policymakers to turn those solutions into real change. Today's briefing is specifically focused on what the new law means for healthcare. It's sadly the last of our 4 briefings we're doing with the center, specifically about this law, but like I said, feel free to tune into 2 of the other recordings online. This one, like the 2 that preceded it, is also on the record and will also be recorded and shared. You can access the recordings from the other 2 topic-specific briefings we held on our website if you're interested. And please, we cannot encourage you enough to drop questions in the chat you might have for our guest throughout the conversation and his presentation, and then we can kind of get to those at the end. With that, it's my honor to introduce our very accomplished speaker who is bravely helming this session by himself. I believe you're the only one, Jonathan, who has not had a buddy to kind of play off of. So kudos for going to the lion's den, I guess, without a metaphorical chair. I'm not sure what the right analogy is there.
I think being a sucker is what you're looking for, but
Love it. It's very brave. Jonathan Burks is the Executive Vice President for Economic and Health Policy at the BPC. He is an experienced senior public policy professional and corporate board member who has worked for over 2 decades in the public and private sectors. Until February of this year, Jonathan was Vice President for Global Public Policy at Walmart, where he led the global retailer's efforts to analyze and develop positions on pressing public policy issues. Before joining Walmart, he was a partner at the global consultancy, the Brunswick Group, where he was the co-lead for the U.S. Public Affairs Office. Before moving to the private sector, he served as the Chief of Staff to Speaker of the House Paul Ryan, where he was the Speaker's principal advisor on policy, strategy, and management. Jonathan also advised Senate Majority Leader Mitch McConnell on budget and appropriations issues, served as Policy Director of the House Budget Committee, Director of Legislative Affairs at the SEC, Senior Advisor to the Undersecretary of the Treasury for International Affairs, and Policy Advisor in the Transition Office of the newly created Director of Intelligence. In 2012, Jonathan was the Deputy Policy Director on the Romney for President campaign. Early in his career, he served for 4 years at the White House, working first for Vice President Cheney and then for President Bush in a variety of positions, including as the VP's Staff Secretary, Associate Staff Secretary to the President, and Special Assistant to the President for Policy in the Chief of Staff's office. He has a master's degree from the School of Advanced International Studies at Johns Hopkins and a Bachelor of Science in Foreign Service from Georgetown. And he lives with his wife and children in Arlington, Virginia. That is a DC resume if I've ever heard one. I mean that as a compliment.
Well, as they say, I can't really keep a job is really what this is.
I love that. Your wife must love that. That's great. Let's get into it. Jonathan, feel free to kick us off and we'll go from there. Audience, feel free to drop your questions in the chat. And like I said, we'll get to them later.
Great. Thank you so much, Allison. I'm really excited to be here and to have a chance to talk about the reconciliation bill. Let me go ahead and share my screen. Hopefully this works. Can you see that? Oh, nope, you're seeing more than I do. Let's try this again. Apologies. It never works out quite as simply as I'd like to. Beginning. Sorry, hold on 1 second. So I'm going to start the slideshow. Okay, I'm gonna hope you can see what I'm sharing, and let me know if not. Okay, great. Thank you. So today's topic, obviously, the healthcare provisions in the reconciliation bill. Oops, probably help if I use the right keyboard. Here we go. We talked a bit about BPC already, so I won't belabor the point, but I'll just note that the unique thing about the Bipartisan Policy Center is that we are the only think tank that is dedicated really to that bipartisan aspect and really thinking through policy from the beginning to the enactment on a bipartisan basis. So let's talk a little bit about the big picture on what was happening in the reconciliation bill. First off, U.S. debt and deficits are high and rising. So before the enactment of the reconciliation bill, deficits were already talking about multi-trillion-dollar deficits. The net effect of the enactment of the reconciliation bill is to accelerate that. And so now we're expecting to have $2 trillion deficits essentially as far as the eye can see. And so you can see that each year we're expecting that to be the case, reaching nearly $3 trillion by the end of the budget window. Now, how do we get there? So there's $4.5 trillion of net tax cuts in the reconciliation bill. There's a relatively small amount, $300 billion of new spending. And then where we're going to focus our attention today, which is the $1.5 trillion in spending reductions. And most of those spending reductions are in Medicaid. Willie Sutton famously was asked, why did he rob banks? And the answer being that's where the money is. And that's in fact the reason why Medicaid is part of the discussion here in the reconciliation bill. It's the fifth largest federal program after Social Security, Medicare, defense, and interest on the national debt. And so if you are going to look for places to reduce spending, Medicaid is one of the first places that policymakers are likely to look. The reconciliation bill takes just under $1 trillion out of Medicaid. And so that is a significant amount of money, obviously, over 10 years. And the because of the way that Medicaid is structured, it creates a lot of additional issues around implementation. So just really brief background around Medicaid. It is a federal state program established in 1965 where the federal government picks up about 63% of the annual spending for the program. Despite that, the federal government takes the majority of the cost. It is the largest part of state budgets. And so it's about 30% of state budgets overall. And in any given state, it's the top spending program and largest part of their budget. So the program provides health coverage for about 78 million people, primarily low-income adults and children, individuals with disabilities, and then lower-income seniors. So how's Medicaid changing in the reconciliation bill? Well, the vast majority of the savings come from just a handful of provisions. And so let me walk through each of those, and I'm happy to take questions about those at the end. The biggest chunk of savings comes from the community engagement requirements. And so that's often called the work requirement. But it's important to note that it is not simply work. So if you're an able-bodied adult participating in the Medicaid program and you don't have children under the age of 14, then you are responsible for completing and demonstrating to the state that you have completed 80 hours of work each month, or community service or schooling, or that you are otherwise exempt. And so this is one of those areas where, as we'll talk about in a bit, the federal government will need to provide additional guidance to the states as to what might mean you're otherwise exempt. And so this requirement that you are engaged in the community is effective in 2027. But importantly, the bill builds in the opportunity for states to demonstrate that they're making a good faith effort to implement the requirement. And if the CMS agrees, the Center for Medicare and Medicaid Services agrees, then this CMS administrator can extend the implementation date to 2029. But that's at the discretion of the CMS. And so that's a significant provision and the largest single cost savings in the bill. Second, we've got eligibility redeterminations. So as noted earlier, Medicaid is a program that is aimed at low-income individuals generally. And so in order to be eligible for the program, you have to demonstrate that you're low income or otherwise qualified. Under current law, under law prior to the enactment of reconciliation, these determinations will be made annually as to whether or not a person is eligible for the program. The reconciliation bill extends that and makes it so that you have to do it every 6 months to determine whether or not you remain eligible for the program. So this is a significant change. This has been an area of policy change over the last several years because during the pandemic, it was the requirement for redeterminations was suspended, and that basically ran through 2023, that suspension. And then starting in 2023, individuals had to start demonstrating annually, again, that they remained eligible for the program. This new requirement to do it semi-annually begins in 2027. And this is one of those areas where if you are a low-income individual, they tend to have higher volatility in their earnings. And so that's one of those areas where if someone was eligible in January, they may not be eligible come July. And so that creates a certain amount of churn in the program and potentially changes how the eligibility, whether people are going to be able to participate in the program, and frankly, just the paperwork burden and the burden of demonstrating income and all the rest can pose a barrier to individuals continuing to participate in the program. The third major set of provisions is around provider taxes and state-directed payments. Here, we're going to get a little wonky and talk about how the states finance their side of the federal state Medicaid program. So if you are a state, you obviously have to generate some amount of income in order to meet your share of the program's cost. And so 49 states, everyone except Alaska, impose special taxes on their medical providers in order to meet a portion of their costs. This decision or this funding option has long been a source of contention between the federal government and the states. And so prior to the enactment of the reconciliation bill, there were limits on how much state can rely on these special provider taxes in order to fund their share of the costs. And so what the bill does is ratchet it down. So if you are, the pre-existing limits were at 6% of net patient revenue, which is to say how much the Medicaid program is spending on patients. And so if you are a state that has expanded Medicaid under the Affordable Care Act, then you have a hospital tax or a tax on another set of medical providers that is above 3.5%. Then starting in 2028, you have to phase down that amount until it gets to 3.5% by 2032. And so that's a significant change in sort of how states are going to be able to finance their share of Medicaid costs. And again, that's specific to the expansion states. Non-expansion states will continue to have the option of having rates up to 6% of that net patient revenue. Now, you might be wondering, why is it that if I'm a hospital, I'm not raising, making a political fuss or ruckus about having to pay these special taxes that no one else in the state has to pay? Well, that's the second half of this provision, which is the state-directed payments. So what a lot of states have done is, in addition to enacting provider-specific taxes, they have also provided for increased reimbursement rates for those same providers. And so the state directs payments to those providers in a way that more or less holds them harmless from the tax that they're paying. And so this has been viewed in a lot of quarters as abusive of the federal-state partnership. And so what this bill does is say, if you are a state that has expanded Medicaid under the Affordable Care Act, then the rates that you pay to providers is capped at the rate that the Medicare program, which is administered at the federal level, pays to those same providers. Again, non-expansion states are treated differently, and for them, they have the option of paying up to 110% of the Medicare rate. And then finally, the final big driver of cost reductions in the bill is two provisions that suspend Biden-era regulations that were intended to ease enrollment of low-income individuals into Medicaid. So they're suspended for the 10 years covered by the reconciliation bill. And basically, these regulations provided for easier data sharing between Medicare and Medicaid and other facilities to streamline the enrollment of individuals. And so suspending these two regulations will essentially make it a little bit more difficult for individuals who are potentially eligible for Medicaid to demonstrate their eligibility going forward. The bill also creates, we talked a little bit about the fact that there's about $300 billion of new spending in the reconciliation bill. $50 billion of that is in the healthcare space for this new rural transformation fund. One of the concerns that was raised during the debate on the Medicaid bill or on the reconciliation bill was the fact that rural hospitals in particular are being challenged by the current economics status. And so this $50 billion fund was intended to provide a means of supporting those providers. And so basically $10 billion a year for 5 years. Half of the money will be evenly distributed to all the states. And then the other half of the money will be allotted based on the administrator of the Center for Medicaid Care and Medicaid Services determination so that they get an opportunity to respond to these state plans that states are going to be required to provide. So states are going to have to apply for this funding. The guidance for that will come out here in September. And essentially, they will need to describe how they would use the funds to improve rural populations' access to providers, health outcomes for those populations, or other factors that you can see there on the right side of the slide. And so the states will provide a plan, and by the end of this calendar year, CMS is responsible for approving or disapproving those plans. And so that's a one-time application for all 5 years. And I think if, as we've talked to some of the states that are in the process of figuring out how to respond to this program, the timelines for this are very tight, and that's going to be one of the challenges we'll talk a bit about going forward. So other significant changes in healthcare. Across Medicaid, Medicare, and the health insurance exchanges, participation by non-citizens is pretty strictly restricted. And so in order to be eligible for participation in these programs and not be a citizen, you need to be either a legal permanent resident, so a so-called green card holder, a compact of free association migrant residing in the U.S., or certain Cuban and Haitian entrants. And so that's a significant change from current law, where there are other classes of documented immigrants who are able to participate in some of these programs. They've also tightened the access to the exchange subsidies. So this is one of the significant areas where waste, fraud, and abuse is arguably being addressed, where in order to be a new enrollee to get subsidies on the health insurance exchanges, you have to demonstrate before receiving those subsidies that you're eligible. Prior to reconciliation, you could start receiving those subsidies based on the assumption that you were eligible, and then demonstrate it during a period of time. And then it also significantly requires that once you've received subsidies for a year, that you have to complete the reconciliation process in the next year, and essentially filing your taxes, demonstrating that you were in fact eligible for those subsidies. Which then ties into the next provision around recapturing subsidy overpayments, which goes to the question of if you are your eligibility for the subsidies is determined based on your expected income during the year, and the amount of subsidy you get is based on that expectation. But as we discussed earlier, if you're a low-income individual, you tend to experience more volatility in your income, and so it could turn out that you had more income in a year than was estimated, and therefore the subsidy you got was too large based on what your actual income was. And so under prior law, you could be required to repay some portion of that overpayment. Now you're required to repay the entirety of the overpayment. So on net, the effect on the healthcare system, we expect to see around 10 million fewer insured in 2034. Approximately 8 million of those will be fewer Medicaid enrollees. And then we expect about 2 million fewer subsidized participants on the health insurance exchanges. And so, about 2 million of that 10 million comes from the restrictions on non-citizens. About half of it comes from folks who are not meeting the community engagement requirement or not expected to meet it. And then about 2 million of it is based on sort of the more strict administration of the eligibility requirements. And then more recently, CBO has estimated that the net effect of the bill will be a small decrease, about 0.6 percentage points lower benchmark premiums on the exchanges, which is to say the premium that is used for setting the overall subsidy should be slightly lower by the end of the window. So that's the major healthcare provisions. Let me turn to SNAP now, which is the second largest category of spending reductions in the bill. Almost all of those savings come from these four provisions: tightening the work requirements, principally the increase in the age that individuals are expected to work, so up to 64 now. And then restrictions on the Secretary of Agriculture's ability to waive work requirements based on local economic conditions being difficult. Important change in the program was also enacted here in terms of, for the first time, states are going to be required to pay a percentage of the program costs based on their error rates. And so if they have error rates above 6%, so they're making erroneous payments above that threshold, then they will face cost sharing up to 15% of the program. So right now, only 8 states and the Virgin Islands have error rates under the threshold. So this is a significant change. For the first time, states will have some financial responsibility for the SNAP program benefits. Next, thrifty food plan reevaluation. So the amount that of SNAP benefit that you receive is based on what's called the thrifty food plan, which is essentially a basket of goods developed by the agriculture department, viewed as sort of a weekly meal plan, if you will. And so the bill restricts the flexibility of USDA in sort of determining the composition of that basket and updates to that basket, which is something that had become of issue late in the Biden administration when there were proposed changes to that thrifty food plan that would have resulted in significant increases in SNAP spending. And then finally, administrative cost sharing. So as noted earlier, states will now face financial consequence if their erroneous payments are too high. And so ironically, one of the provisions here is that the administrative costs of the SNAP program, which have always been shared between the federal and state government, the federal share of that is going down to 25%. So what comes next? Well, on rural health, we expect guidance from the CMS on how states can apply. And that will be important guidance that states are anxiously awaiting, because as noted, it's not a lot of time for them to prepare these plans and get them approved by the end of the year. And then we've got to have implementation challenges. There are new muscles that states are going to have to build in order to comply with this law. So infrastructure to support the new or more stringent work requirements is something that states are going to have to develop. And we've seen the experience that we've had with work requirements on Medicaid in Georgia, have been well reported, and sort of there are a lot of administrative issues you have to work through in order to get this in a workable state. And then finally, the ability of states to drive down the administrative burden on beneficiaries and also the cost themselves of more frequent eligibility determinations. It is a paperwork burden. It is a burden on a low-income individual's time. And so I think states are going to need to work hard to figure out how to make it less burdensome than it might otherwise be. And then finally, this is going to put a lot of pressure on state budgets. Most states have a binding balanced budget requirement. And so they're going to have to figure out whether they want to increase taxes to pay for their share of this spending, or whether they're going to reduce benefits. And so one of the things that folks haven't often thought about is that SNAP participation is voluntary. So states are not required to have a SNAP program. I find it hard to believe many states would choose not to continue to participate in the program. But the reality that there is now a state budget cost to them of the program means that at least some states will consider it. And then finally, on the Medicaid side, states have a set of services that they are required to provide as part of their participation in Medicaid. But then there are a basket of optional services that states really, will have to choose which of those they continue to do, given the fact that they now have a increased cost share of that. So thank you. Always happy to answer questions here today. And if you have additional questions, my colleague Martina McLennan is available at this information. So with that, I will take down my screen, and then Allison, fire away.
Sounds great. You can hear me okay? Now that I'm back. Okay, fantastic. Well, that was really, really helpful. Thank you so much. We do already have a couple of questions, so I will get to those first. Someone asked, and I believe this was earlier when you were talking about Medicare and Medicaid, was the overpayment requirement always part of Obamacare / the marketplace?
Sure. So the rule, there were always rules around what would happen with respect to subsidy overpayments. So part of ACA, it was capped, however, how much an individual would have to repay if there were an overpayment. And so basically what this does is remove that cap.
And is the thinking that I'll just add on to that, is the thinking it just saves money then by not having a cap?
Yeah, I mean, it saves money, and I think there is a fair bit of evidence of some abusive practices in terms of individuals underreporting their income in order to boost their estimated subsidies, and then knowing that they wouldn't have to repay all of it at the end of the year. And so that's the dynamic that Congress was seeking to address, and by removing the cap, there's no longer that incentive to sort of underreport.
Gotcha. And then we have another question too. Do you have an estimate of what all of this will mean for insurance premiums? I think maybe you had a data point in there, Jonathan, unless I
Yeah, so
misremember.
so what CBO has said is that it thinks there will be a small, I think it's 0.6% percentage point reduction in benchmark exchange premiums by the end of 2034. So by the end of the window. Now, obviously, looking at the effects of this bill in isolation ignores sort of the other changes that are going on in the healthcare system. So, there's a lot of, there's been early reporting for sort of the coming plan filing year that we were looking at double-digit percentage point increases in the bids that insurers are offering for exchange for the exchanges for the coming year. So, this is a dynamic environment where there's a lot of different factors that will change, obviously, over the next 10 years. So, take it with a grain of
Gotcha.
salt.
Gotcha. Just a reminder to the audience, feel free to pop your questions in the chat. I have some that as a journalist also came up with a few while we kind of wait for more from the audience. But I'm curious, I feel like in the last decade, we heard a lot of talk about Medicaid expansion among the states, and certain states that did this, didn't do this, or, pushed back against this. How does this affect that conversation at all? Or maybe states who did expand?
Yeah, so as I noted, states that expanded Medicaid, which is most states at this point, face a different set of Medicaid rules going forward than those that did not. So that's especially true in the provider tax and directed payments area, where their ability to use the provider tax as a financing mechanism and state directed payments as a means of sort of that combination as a means of financing their part of Medicaid is going to be more restricted. So they'll have a lower percentage of income that they're able to drive from providers, and then they won't be able to send as many dollars back to the providers as states that haven't expanded.
Gotcha. Okay. Would that, in theory, I guess, what's the trickle down effect of that? Do then you see providers, drop taking Medicaid patients, or what does it look like on the ground in these situations?
Yeah, I mean, I think it's an open question. Part of it will depend on how states choose to raise the income, the revenue that they're going to need to meet their share. So states have flexibility in determining sort of whether they enact a broad-based tax of some sort in order to meet their share, or if they choose to reduce optional services in Medicaid. So those are sort of two options in order to sort of lower, they could try to lower the cost by removing optional services, or they could try to raise revenue in other places in order to meet their revenue share. And so it's unknown at this point how states will react. But I expect, obviously 50 states will probably end up with 50 different answers.
That makes sense. We have a question from the audience I'd love to get to. How can accountability be put onto the insurance companies / brokers who are signing ineligible people up for marketplace plans?
Yeah, no, it's a great question. I think part of so you're eligible for the plan, or you're eligible to participate in the marketplace as long as you don't have other insurance. And so the real question is sort of the subsidy piece. And so there is a question about sort of whether you as a insurer or as a broker active in this space, if you are participating in sort of deliberately overstating, or deliberately understating a beneficiary's income, that would be potentially, actionable by CMS, which at a national level oversees the exchanges. And so there are questions about sort of how much of this is deliberate on the part of insurers, how much of this is deliberate on part of individuals, how much of this is sort of auto-enrollment aspects. So some people are auto-enrolled in plans, not necessarily recognizing that they're participating in a exchange plan. And so for those who are in that circumstance, it could be sort of a no-fault issue that their income is being understated. And so the intent of the provision is to require the plans to, in fact, make the determination upfront before they go and provide that information to the state or to the exchange for the subsidy.
Do you think, I'm going to rephrase this one question a little bit. Do you think that any of these changes will cause fewer people to enroll in the marketplace?
Yes. So CMS's estimate, or excuse me, CBO's estimate is that about 2 million fewer people will be enrolled in the marketplaces as a result of sort of all the changes in the bill. And then there's a scheduled expiration of the enhanced premium tax credits that is planned to happen at the end of this year unless Congress acts. And so that is estimated to have, an impact of several million more individuals not participating in the exchanges going forward.
And that 2 million, I just want to clarify that. So that's not, is that so much, I guess, that's not from people being afraid or being pushed out of the marketplace. It's people being declared ineligible, it sounds like, by the new law, if I remember your presentation. Can you clarify that?
Yeah, so of the 2 million that are expected to not participate in the exchanges because of the bill, 1 million of that is that they will not meet the upfront eligibility determination, that they'll either fail to provide the paperwork or will provide the paperwork but not be eligible for the subsidies. So.
Gotcha. Okay, that's helpful. That's helpful. Let's see, we're getting a bunch of questions. What is the predicted healthcare cost increase associated with the 10 million newly uninsured?
Yeah, so it's interesting. Well, I guess I'll put it this way. It's hard to say, in part. One of the assumptions or one of the pieces of analysis that CBO has done suggests that many of the individuals that will be leaving or losing insurance were better health risks, which is to say healthier in general than the overall pool. And so that suggests that you may not see a sort of huge change in sort of healthcare utilization or health outcomes, which are correlated with cost. But it's hard to say. Sitting here today, whether you'll see overall healthcare spending being markedly different economy-wide, even as the estimate is that the public spending for those beneficiaries certainly will lower.
Gotcha. Can you talk about the effects the bill will have on providers? Will fewer of them take Medicaid patients, and how much will that 50 billion for rural hospitals help, given that much more money than that is being cut from Medicaid?
Yeah, no, that's a great question. I think one of the things we can expect, driven in part or significantly by the changes in provider taxes and state-directed payments, is that you will see some providers opting out of taking additional Medicaid patients. And so, the reality that Medicaid payment rates are often considered by providers to be uncompetitive suggests that, it's always a challenge in that system to maintain provider participation. And so I think that what we should expect is that we'll see sort of greater challenges in respect to getting provider participation.
If millions of folks will now not have access to Medicaid, do you have ideas of how they will get their health care? Won't they just show up in emergency rooms or free clinics, bombarding those resources?
Yeah, so there's certainly a challenge of sort of uncompensated care that we'll be monitoring going forward. Certainly, whenever access and coverage numbers decline, you have to think about sort of how people are going to access the healthcare system. And I think one of the challenges certainly is likely to be uncompensated care demands going up.
And someone has a question here. I'll front load it by explaining that this is a term that's a holdover from the Obama administration, which thank you to this person for adding that. So the invincibles won't re-enroll in these policies.
Yeah, I think there's certainly some individuals who didn't view the might not value the exchange coverage as much as because they view themselves as healthy and invincible. So that's certainly one element of potential change that you could see in sort of the makeup of the covered population. The reality that health insurance is a means of managing financial risk implies that individuals have to recognize that they're at risk. And so those who don't believe themselves to be a significant risk, their willingness to pay is lower. And so if you're reducing the subsidy, that means that they're likely not to choose to manage the risk that way.
I'll go back to audience. Feel free to pop in more questions into the chat. I want to go back to you'd kind of mentioned SNAP, and I know we haven't really touched that in some of the Q&A. So if states are, I want to go back to kind of the error rate you mentioned that states, I think it was 15%, they'll have to kind of account for. If states have to pay based on the error rate, it sounds like, is it right to read that as that's an incentive being put on states by the federal government to basically rule out any issues at the state level with executing the program? Because then they have to pay.
Yeah, I think if you were talking to friends on the Agriculture Committee majority staffs, they would say the 6% threshold for erroneous payments, that most states used to meet that, and that states are more than capable of administering the program in a way that doesn't have error rates above 6%, is their view. And so the challenge, of course, is making sure that in an ideal world, you want to make sure that everyone who's eligible is getting every dollar of the road, and that no one who's ineligible is getting any dollars. And the challenge is that in the real world, administration can be difficult. And so this is intended to put skin in the game for the states, because right now it's 100% federal cost. And so if you're a state, the incentive is to go ahead and enroll the marginal applicant and make sure that, because there's no cost to your budget. By creating this cost, that the intention is to make sure that states do a better job of administering the SNAP benefit.
So when you say marginal applicant, like if you're on the border, maybe if you should be enrolled or not, maybe they'll err on the side of caution and not enroll you. Is that?
Well, I say marginal, and I really mean sort of the beneficiary for whom you may not have fully completed the eligibility determination.
Gotcha.
You have high confidence in sort of the income documentation that you've been provided or whatever. So
that's helpful. That's helpful. Let's see. Oh, here's another question from the audience. Are you aware of how any states plan to build systems to take on work requirement checks and income eligibility checks? What can states implement from the Medicaid redetermination that took place last year?
Yeah. So I think that is definitely going to be one of the big questions for states over the next couple of years as they start implementing the community engagement requirement. Ultimately, states have for years now had a SNAP work requirement that they've had to administer. And so I think some states will choose to build on that same system in order to not reinvent the wheel in that respect. But as noted, Georgia, which has been operating a Medicaid work requirement under a waiver of demonstration program under Medicaid for a couple of years now, there are challenges that arise in sort of being able to demonstrate that someone is meeting the requirement. And it's especially more complicated as you move out of sort of simple work where you have, say, a W-2 being generated. If it's community engagement, how do you demonstrate that you were volunteering for the 80 hours a month, or how do you demonstrate you were engaged in taking care of a family member, which is one of the categories of exemption. And so those are challenges that states are going to have to build systems in order to comply and to have confidence that they're getting it right. So I think states are going to take a variety of approaches, whether that's contractors, whether that's building capabilities in-house. But, I think that's one of the things that I think a lot of states are starting to have conversations about and are very concerned, bluntly, about their ability to do it on the schedule established in the bill. And so I think a lot of states are going to be looking to CMS for the extension that is available if they're making good faith efforts towards compliance.
A quick question of mine onto that. So do you think a lot of states, or have you seen states already looking to Georgia maybe as like an example of a state that's already worked with on maybe on ironing out some of these hiccups? Or
Yeah, I know there have been some conversations, and I think this is actually one of the areas where BPC intends over the next several months to be helping facilitate some conversations and help facilitate some lessons learned about how to administer this requirement in a smart way. So.
for sure. For sure. Another question from the audience. Will the Medicaid changes have a trickle-down effect on charity care that hospitals provide? Kind of similar to our earlier question on what
Yeah,
this will look like.
yeah. I mean, I think there's certainly aspects of the bill that will end up sort of increasing demand for uncompensated care. And I think that's just one of the realities. Whenever coverage numbers change, you end up with a circumstance where there's the potential for increased demand in that respect.
And to follow up to that, will the rural health funds only be allowed to go to hospitals, or will there be options for other forms of rural care, like rural/community health clinics, school health clinics in rural settings?
Yeah, no, it's a great question. Everyone sort of talked about it as a rural hospital fund, but in fact, the statute provides that it's a lot of flexibility for what it could be used for. And so states will have to put together a proposal on sort of what they intend to do with it and that could include things like health clinics or school health clinics. And I think that'll vary by state, sort of what they choose to prioritize within their packages. And then, this will likely be an iterative process with CMS in terms of, states will propose what they want to do. It doesn't necessarily mean that CMS will approve that use. And so I'd be surprised if there weren't at least some back and forth with some states on proposed uses.
Mm-hmm, mm-hmm. What impact will the bill have on people who are disabled? What kind of documentation will they have to produce, especially those who are not fully disabled, but their disability hinders their ability to work?
Yeah, no, that's a very, that's one of those areas that CMS is going to have to produce regulations about exactly what qualifies as disabled for purposes of the community engagement requirement. There are, under current law, one of the qualifications, one of the ways an individual can qualify for Medicaid is disability. And so, exactly how that will work will depend in part on the regulations that CMS issues in the coming months.
I'll throw a follow-up to that. Yeah, is there a timeline on issuing those regulations, or what should reporters watch for on that front?
Yeah, I don't believe there's a strict deadline for issuing the regulations on that respect, but I believe CMS has announced that they want to do that they intend to do so this year in terms of trying to get regulations out, recognizing that the community engagement requirement is complex and it's novel, and so giving the states as much time as possible to build the systems needed to comply, I think is in everyone's interest.
Sure. I think this is another one kind of following up on that. Have the U.S. territories like Puerto Rico and the U.S. Virgin Islands, have they been excluded from all of the bill's provisions?
No, so it depends on which provision one is talking about, exactly how they apply to. So I couldn't, sitting here right now, sort of walk you through each provision, but would be happy to connect offline and talk about sort of how different provisions apply. But it's a real mixed bag.
Gotcha. But no, it's a good, helpful overview. Going to SNAP a little bit here, pivoting. Do the changes affect the expansions of the restaurant meals program? Do you have any knowledge of that?
That is not ringing a bell off the top. I'm sorry.
No, that's okay. That's okay. To whoever asked that in the audience, feel free to circle back. I think we put the spokesperson for Jonathan, or the comms person for Jonathan, in the chat. So feel free to follow up with any follow-up questions you have on that front. And then another question on kind of a specific facet. Do you have any thoughts on the passage of the Orphan Cares Act within this bill? Do you think this will have a significant impact on drug development in the future?
Well, I mean, it's intended to. I think it's a question mark. If you ask policymakers on the orphan drugs front, there has been dissatisfaction for some time about whether it's done enough to incentivize development of treatments for diseases with smaller populations, and obviously that's one of the motivations for enactment of the provisions here. But I think it's an open question as to how effective they'll be. This is one of those areas where there's actually a fair degree of bipartisan agreement about the need for the program to work better. But and so it's a question of how the real world reacts to good policy intentions.
What could uncompensated care demands going up mean for hospitals and patients who can't afford medical expenses?
Yeah, I mean, so if you are in need of emergency care, federal law provides that providers have to essentially stabilize your condition, and then what often happens is individuals are faced with medical bills that if they're unable to pay, eventually get written off by the hospital, and there are some provisions in both state and federal law that compensate hospitals for some share of that uncompensated care, but obviously the challenge of accessing medical care without the means to do so is universal, and the challenge of that is real, and because there will be people with an estimated 10 million fewer with health insurance, that means sort of 10 million more people who will potentially face those issues.
Mm-hmm, mm-hmm. We're going back to SNAP here with one of the questions. How is the SNAP error rate calculated? Does it only include people who were inappropriately deemed eligible, or does it also include people who were erroneously deemed ineligible? I think if I were I see your confusion. I think that means was it people who were actually ineligible or shown ineligible been deemed ineligible by accident?
Oh, so I think yeah. So basically, if you mean deliberately, people who sort of were committing fraud, or if I understand the question, and I'll answer it this way. The error rate includes people who sort of deliberately were misrepresenting sort of their eligibility for the program, and those who might have been given sort of larger SNAP payments than they were eligible for, either because of income changes or family size changes that they misreported or that were misreported. So it can be things that are perfectly innocent or things that are fraudulent. Yeah, both are included in that error rate.
And whoever asked that question, feel free to, if we misinterpreted that wrong, feel free to pop a follow-up into the chat as well. We have a few more minutes for questions, so if you guys have any more, definitely feel free to put them in there. I'll ask too, I guess, as far as it's our states, I know there's kind of been a theme, it seems like, with the bill overall, and not just related to healthcare, but other things about kind of some new burdens being placed in the states, whether that be financial, procedural, what have you. Are you expecting states, I'm curious, to implement these policies to have to staff up further, or maybe change kind of their staff makeup? What does that look like day to day? If you're a state, are you kind of freaking out right now, or what's the vibe?
I think it varies. Some states are more prepared than others. Some have higher administrative capacity, sort of on a normal day than others. Excuse me. And so one would expect that there are probably some places where states are going to need to hire additional staff in order to build out systems. Some states are looking at contracting, with vendors in order to sort of purchase systems. And so it'll probably be a mix depending on the states involved. And, I think there are efforts underway to coordinate on these things so that potentially, if you are willing and able to coordinate your state's policy with another state, you may be able to, buy a single solution from a vendor as opposed to have the vendor build two very similar but distinct systems and charge you both for maximum profit.
The power of a big group, yes, on pricing. We have another question from the audience. This is a good kind of one to get toward the end. Given your note on the deficit at the beginning of the presentation, do you think there will be a reconciliation 2.0, and will it take a further cut out of Medicaid/Medicare, et cetera?
Yeah, there's obviously been some discussion of a Medicare 2.0, or excuse me, of a reconciliation 2.0. I'm a little skeptical that that's likely to happen. If there were a lot of appetite for additional either spending cuts or tax increases or other policies, it probably would have ended up in this bill. And so, it seems to me that there's probably not a huge pent-up desire for additional cuts in this context. But, the reality of very large budget deficits going forward is mitigated somewhat by what appears to be a much higher level of tariff revenue, which is to say taxes on imports that the president has imposed. And so, the deterioration of the fiscal picture that was caused by reconciliation may somewhat be mitigated by that. But you still have sort of the underlying trend of what, $1.7 trillion or so a year of deficits that is ultimately unsustainable. And so whether it's through a reconciliation 2.0 or through future legislation, Congress is eventually going to have to deal with the challenge of righting our fiscal ship.
Another question here. Do you foresee any positive outcomes from the big beautiful bill healthcare provisions?
Well, I think there's, I came up in Republican politics, and so I'm someone who's long favored sort of greater devolution of federal programs to the states. And so I think there's opportunity with respect to giving the states more authority, more flexibility about how they administer their programs. So I'm not, so I think that there is the reality of states having sort of a greater financial stake in how these programs are administered will hopefully help states get a little bit more adept, more expert in how they administer their programs. And so that's one of the challenges of a federal state program is that if the federal government is bearing most of the cost, your incentive as a state to manage the program as efficiently as possible is less than. And so as you start bearing an increased share of that cost, your incentives grow as well. So.
And like if it's dad's money, you're more willing to spend it maybe than if when you start making your own money.
Exactly.
Good. Something I like to end on, as we're kind of wrapping up here. I don't see any more questions in the chat. I always like to ask people, what do you see, as you're very steeped in the healthcare space and also like we talked about SNAP, what I guess is there anything you've been surprised the press hasn't covered more that you think maybe hasn't gotten, the coverage you were expecting or that it even deserves, like any changes made to policy as part of the bill?
Well, I think the area that I am most interested to see how states engage is on the eligibility determination space. I think that is one of the big challenges states will have. In doing it twice a year, it becomes both more expensive and more burdensome. And there's got to be smarter ways to do this than sort of very manual processes that many states are engaged in presently. And so I think that's one of those areas that it bears closer scrutiny because ultimately, if you have individuals who are eligible for the program, you want them to be engaged, fully enrolled in the program. And so being more efficient about how you get them go through that process is going to be a real important part of making sure that the spending cuts that are in the bill don't ultimately end up with worth care.
Mm-hmm, mm-hmm. Can you tease out really quick, Jonathan, just as we have a few more minutes, kind of, is that like, do people have to go in person to do that usually every year, every 6 months now in this case, or what? Yeah.
It really depends on the state.
Okay.
And so, there are places where, you've got to sort of bring all this documentation manually into an office and demonstrate it. There's other places that have more electronic systems. And then obviously you're dealing with a low-income population that may not have access to sort of more digital based systems. And so you've got to balance the availability of sort of these more traditional manual processes with what might be a more efficient online system. And, so the great thing about our federal system is that there's a variety of approaches states can take and experiment with. And so I expect that to be one of those areas where we'll see different states take different approaches, and we'll hopefully see the states learning from each other about what is most efficient and most effective and making sure that people get the access to care that they need.
Well, on that note, thank you, Jonathan, so much for delving into all of this for us. I think our my staff member who's kind of helping us with this already put our survey link in the chat. If you've attended this the whole time, or we've had this for every briefing, we'd love to get your feedback on how it went. The Institute uses it to kind of inform our future programs, which it always really helps us. Thank you all so much for joining us. This is, like I said, this is the last event in our 4 briefing series on the Big Beautiful Bill. These have been a blast to hold with all of you over the last few weeks, and we're really grateful for everyone's fantastic participation. That survey, if you didn't grab the link in the chat, will also be coming to you in your inbox, so keep an eye out on that. And we're also going to share our link to donate, I believe. Yeah, I'll prompt our staff to do that.
If you weren't already, you are now.
Yes, please. Yes, exactly. The Institute tries to provide a lot of this programming, like this program itself, free to journalists so that as many people as possible can access it. But donations are a really big help to us. So thank you all again for being here. Keep an eye out for the recording and Jonathan's awesome, really helpful slides. Those will be available later online. And stay well. We hope to see you all again soon.
Allison, thank you so much. Thank you everyone for the questions.
Thank you. Thank you. Bye, everyone.